Good evening, everyone. On behalf of the IIP Digital team, I, Dr. Manisha Tarpalikar, welcome you all for today's webinar. Today's webinar has been organized by the IIPWC Utkal branch. Dr. Priyadarshini Mishra will be the moderator for today's session. We are live streaming on our official IIP India YouTube channel. I request all participants to kindly join and subscribe to this channel to receive regular updates and view the upcoming webinars. If the participants have any questions, I kindly request them to write it in the chat box. They would be answered at the end of the session. I now request Dr. Priyadarshini Mishra to kindly take over. Thank you.
Thank you, ma'am. Thank you for the introduction, ma'am. Good evening to all the participants and the panelists present today for this evening. I am Dr. Priyadarshini Mishra. I am IAPWC State Coordinator, and I'm working as Associate Professor and IQAC Coordinator at Institute of Health Sciences. I'm the moderator for the day. We have with us Ms. Dhara Shah, ma'am. She is clinical instructor, Wow I Prayer. She is Women's Health Pelvic Floor Specialist. This Wow I Prayer is a one-of-a-kind institution organization which provides education, #1 education on pelvic floor rehab. Our topic for the day is Intro to Gynecological Cancers and Pelvic Floor Rehabilitation. Now I would request Dhara ma'am to take over from here and start the session. Thank you, ma'am.
Very good afternoon to one and all. Thank you very much, Dr. Priyadarshini, for a lovely introduction. First of all, I would really like to thank upon the whole team of IAP India, IAP Utkal branch, IAPWC Utkal branch, Dr. Sanjeev Jha sir, Dr. Ruchi Vashre ma'am, Dr. Sthiti ma'am. Like we have been talking with each other since more than 2 months now, and finally we have made it together. IAP Digital, IAP digital team, Dr. Manisha and Dr. Priyadarshini, thank you very much for organizing this wonderful session on gynecological cancers and importance of pelvic floor rehab. Before I start, I would really like to thank Dr. Desai sir for trusting me and giving an opportunity to me to be into his visionary team. I am really obliged and humbled to be a part of WOW IPRE, that is International Institute of Pelvic Floor Research, Rehab and Education, under the leadership of Dr. Desai sir. So a very warm welcome to all of you. And tomorrow is World Physiotherapy Day. So we all are very, very, very excited, and we want to do a lot of things and lot of work into this field, and we have to make sure that whatever physical therapy was there in year back should be upgraded today, and whatever it is today should be upgraded the next year. So with the same principle, I think that the topic which we had discussed, which we decided for the session on today, that is on gynecological cancers and pelvic floor rehab into it. So in this session, I will give you an idea on how the gynecological cancers are, how do they affect the normal life, and what is the relationship between the pelvic floor and the gynecological cancers. So before we start, I would really like to give a short introduction of Head sir. So sir is an entrepreneur, innovator, and author of Amazon's bestseller #1 in gynecology, urology, Amazon's bestseller in gynecology and obstetrics, and bestseller in physical therapy. And it is his vision with which we all are working, that is to courageously break the cultural taboo and to make intimate health accessible to every single woman and every single man on the globe through innovative technologies and services. And for the contribution which he has made into the field of pelvic floor rehab, the work which he has kept, and the vision which he has developed for all of us, he is popularly known as father of modern pelvic floor rehabilitation. Sir is also the chairman and founder of WOW IPRE, WOW Experience Research and Development, WOW Exercise, AZPFM exercise and video, which all have received certificate of recognition from Government of India. To his intellectual properties, it is PF 360 valve, VSPA valve, when vagina fit, vagina dilate, and many more. And to his intellectual contributions and intellectual properties and academic contribution, it is HITS MMT, HITS FMT, HITS of assessment, HITS clock assessments, HITS female sexual function scale, HITS male sexual function scale. HITS providers protection guidelines through which we are strictly not going into cross-gender, transvaginal, transrectal, pelvic floor treatment or training or treatment, and HITS reflexive result scale. So with this, I would really like, since we have very short period of time, that is 1 hour, I feel that I want to deliver as much as I can in this hour. And but you all know that it is not possible to cover this much depth of topic. So I would really like to inspire you all to get into this field, to work into this field, and to help millions of silent sufferers. So before we understand the oncological part of it, would quickly like to give you an intro of what the female anatomical reproductive organs considered to be are. So this is my favorite model. You all might definitely be knowing it. Those who are meeting me for the first time, it might be new for you. Those who are meeting me time and again, I'm sure you all are also in the love of this model. So when we talk about the female anatomical reproductive organs, we are basically talking about the ovaries, the fallopian tubes, the uterus, the cervix, the vagina, and then the external genitals like the vulva. Okay, so these are the anatomical reproductive organs of a female. Fine. So they consist of the ovary, fallopian tubes, uterus, cervix, vagina, and the vulva. That is the vulva. When we talk about it, is the labia majora and the minor and the vestibule. So when we talk about any gynecological cancers, I would pin myself. So I think all of you can have my screen on your laptop or your mobile. So when we talk about gynecological cancers, these means the cancers which are affecting the reproductive organs of a female. Okay, so gynecological cancers does not include breast cancer. Okay, because breast is not being considered as a part of a reproductive organ, and breast cancer do happen in male as well, whereas the gynecological cancers are the cancers which occurs only in the female, or only in those who have the female reproductive organs into it. So those are the which all cancers can you list down in the gynecological cancers. So those are the ovarian cancers, the cancers of the fallopian tubes, the cancers of the uterus, the cervix, the vagina, or the vulva. So any of these cancers will be categorized into the gynecological cancers. Though breast cancer is not included into gynecological, but I have taken a brief about breast cancer as well, because it is one of the most leading cancers into a female, and the second most leading cancer being the cervical cancer. So when we are talking about the gynecological cancers and the female reproductive tract, when cervical means the cervix of the uterus and not the cervical spine. Fine. That was on a lighter note. So these are the basically any cancers which are affecting any of these reproductive organs. They have been considered to be the gynecological cancers: the ovarian, the uterine, the vaginal, the vulvar. Okay. So I'm not going in detail of the differentiation of stage-wise cancers: 1A, 1B, 2A, 2B, 3, and 4. But these are just this image will give you an idea that when we talk about 1A, that means the cancer is in one ovary. 1B means the cancer is in both the ovaries. 1C means the cancer is in the ovary and the surface. It is not in the stratum, it is on the surface as well. That is 1C. 2A again, types of cancers, and it's categories of cancers. There are multiple nomenclatures and classifications which are being followed. Whichever is being followed, they will always mention about the classification being used by them. Okay, So 2A means it is also affecting the fallopian tubes. 2B means it is affecting the fallopian tubes as well as part of colon. Okay. 3A, 3B means like you can say that the lymph nodes involvement are increasing, and 4 is beyond the abdominal cavity. So it is like almost a metastatized grade 4 cancer. Whenever, see, we need to understand that what are the symptoms? How can you find out what are the early ways to diagnose or to prevent a mishappening to happen? So that is to understand that what are the signs and symptoms and what do they indicate? Where do they indicate? Okay, so the cancers signs and symptoms are as such. The early stage there would not be any symptoms which would be visible, but in the advanced stage, see, the common symptom for all the gynecological cancers would be vaginal bleeding, and does not mean that this bleed is only during the menstruation. It can be for a menopausal female, the bleeding might start again, or even for a female into her reproductive age, meaning between menarche to menopause, she might have intermittent bleeds. Okay, or she might experience intermittent bleeds in between the menstrual cycles. So which was not there earlier, but of lately it has started, and she also is having deep-rooted pain, low-lying pain. So all if these are few of the common signs and symptoms related with increased vaginal discharge. Okay, so dyspareunia, difficulty with sexual activities, or if the cancerous growth is more and it is compressing the surrounding structures, then difficulty with defecation and reduced appetite, and all these things can also accompany. But the initial signs are not very prevalent, but still if you the generalized signs which would be there would be the vaginal discharge, bleeding, pain or pressure in the pelvic area, abdominal or low back pain, quick satiety or difficulty in eating, and frequent urination or constipation. So all these signs and symptoms we can easily understand and correlate that when there is any mass which is growing here, and if it is growing larger and larger, it would be definitely compressing the surrounding tissues. And when it will compress the surrounding tissues, those will be the signs and symptoms. So there are few common signs and symptoms which would be repeated in all the gynecological cancers. First being increased vaginal discharge, second being bleeding, vaginal bleeding. After menopause, the bleeding starts again, or if she's into the reproductive age, intermittent bleeding with the menstruation. That is the second one. Third would be the low-lying pain, a constant low-lying pain or lower abdominal pain. Fourth would be dyspareunia or difficulty in sexual penetrations. If it is in cervical cancer, we would be discussing in the cervical one. If it is in cervical cancer, it can also be associated with vaginal bleed post-sexual activity. Fine. So these are a few of the common symptoms which should draw our attention that it might not just be a random thing, but it can actually be a serious problem. The second being the uterine cancers. So again, not going in detail, stage 1 is the endometrial cancer. Stage 2, when the cancer spreads towards the, 1B means when it spreads towards the myometrium. 2A means the cervix gets involved. 3A means the ovaries are getting involved. 3B means the vagina is getting involved. 3C means the lymph nodes are getting involved. 4A means the bowel and bladder, and 4B means an overall spread of the cancerous tissues. Again, signs and symptoms would be early symptoms are always masked out, and the later symptoms can be, as I said, pain during activity, bleeding, even after menopause, a constant feeling of heaviness into the uterus, constant feeling of excessive heavy bleeding or excessive blood clots, altered vaginal discharge, recurrent infections. So all these things can be the signs and symptoms. The next being the cervical cancer. Now, when we talk about the cervical cancer, these are the cancers which is the second most leading cancer and one of the reasons for death of a female. That is the cervical cancer. Would like to definitely talk a little more about it over here. So you can see in this model. So this is the cervix. You can see the cervix. What do we mean by the cervix? Cervix is the part of the uterus which is connecting the uterine body with the vagina. Okay, so you can see the part of the uterus connecting the uterine body and the vagina, that is the cervix. You can see here, and the cervix has two parts. One is the internal os and second being the external os. So this is the internal os. Internal os means the part where the cervix has been connected with the uterus, and the external os being the part where the cervix is being connected with the vagina. So this portion is known as the cervix, and it plays a very significant role during pregnancy, during sexual activities, as well as into a non-pregnant women as well, even for the fertility. So it is often very much important part, and the cervical cancers are very common for the females who are involved into unprotected sexual activity with multiple partners or multiparous, or the females who are unable to maintain a proper hygiene, who have delivered multiple times as a multiparous. So why do they have the cervical cancers? The causes for the cervical cancer, one of the most common causes being HPV, that is human papilloma virus. Okay, that is a virus which is responsible. It is a huge family of, like, HPV viruses are not just one single virus coming and going. It is a huge family of more than 200 strains into it, and few of their strains are non-cancerous, few of the strains are cancerous. So the HPV virus is the same virus which gives you the moles and warts on your body, fine, and it is responsible for oral cancers. It is responsible for anal cancers, for cervical cancers, for vaginal cancers, for penile cancers. So the spread is through unprotected sexual activity, or through or the females who are involved into an oral sex in an unhygienic way. Right. So what you can see here in the cervical cancer, in the cervix, you can see two portions of the cervix. One portion, like this, is the endocervix, the part of the cervix which is like after the os, which is inside the uterus, uterine lining, the endocervix, and then is the ectocervix. So the surface, the epithelial changes from the endocervix to the ectocervix, and this being in one of the potential site for the cell mutation. So you can also see into the image that the potential site of the mutation can be the junction of the endocervix and the ectocervix. HPV, so there are a lot of government policies going on for giving the vaccinations for the non-sexually active boys and girls. It is not required to have it's not so that only the girls should be vaccinated like the way we do for rubella. Rubella is exclusively for the females, but HPV virus is for female as well as male before they start their sexual activity. So the potency, the viability of the vaccines would be more if it is being taken before they start their activity. Right from the, so it is being said that the ideal age to give it depends like what type of vaccine you are selecting. Quadrivalent, bivalent, there are multiple strains which are available. Bivalent means it will be giving you in resistance with against two varieties. Quadrivalent will be a more stronger one, and you will have it can come in a dose of 2 or dose of 3. So that is a very beautiful work which is being initiated by the government, and I would recommend that those who are mothers of young of adolescent age females or males, it is the right time you get them vaccinated, or you get at least a knowledge about the vaccination from your available gynecologist or the family physician, whoever you are visiting. Because see, all of the cancers, they do not have a strong virology, but HPV, like cancer cervical and the HPV has a strong virology, so we can definitely defend ourselves from it. Yep. So the signs and symptoms are pain within sexual intercourse, in between severe cervicitis, watery discharge, blood discharge, foul smelling discharge, dyspareunia, immediate vaginal bleed after the intercourse. In between periods, there would be excessive bleeding. So all this would be constant low-lying pain, low-lying inflammation. You feel like throughout your perineal area. So those would be the cervical cancers. Followed by that are the vaginal cancers. So vaginal cancers means the cancers which affect the vaginal canal. Okay, they can affect the whole of the vaginal canal. So depending upon the spread, how much is the spread, whether it is only in the inner epithelium, it is covering the whole the whole wall, or it is spreading to the nearby ligaments, or then it is going more beyond the ligaments and involving the other connective tissue, or it is being spread throughout the abdominal and the other contents. So depending upon that can be the vaginal cancers. So almost 85% of the cancers involving the vagina is a result of the spread of the from the body or fewer from the uterus or the cervix. And again, that will it will be. See, now if it is in vaginal cancer, it will compress both the parts, the bladder, the bladder and the urethra, as well as the rectum and the anus. So if it is developing more and more and more, the female initially she might just have pain with sexual activity. She might have intermittent bleeding, foul smelling, discharge, and if it goes on and on, it can give a compression upon the bladder and the urethra, resulting into dysuria, or compression over the rectum and the anus, resulting into constipation. So either of whatever it is, the baseline thing is where is it present and where is it being advancing and what is it compressing. So whatever the thing it is compressing, you will get a symptom over all these areas. Right? So those are the vaginal. Then the vulvar cancers. So vulva, what do we mean by vulva? Vulva means the area from the mons till the perineal body. Okay, so it consists of labia majora, consists of labia minora, the vestibule. Okay, so this is the mons and this is the perineal body. You imagine the skin fold over here. So the outer skin fold is the labia majora. The inner skin fold is the minora. In the minora, we have the vestibule. Fine. So the vulvar cancers are the cancers which are covering the vulva, right from the mons till the perineal body. So those are the vulvar cancers. So the patient might feel there is some scratching or irritation, altered skin tone, altered skin color, then some mole is there, some wart is there, then that wart is bleeding. So then it will advance further. Okay, so depending upon how much deep has it been penetrated and what area has it been covered, it can be diagnosed in grade 1, 2, and 3. So the symptoms can be itching of the vulva, burning at the vulva, pain and tenderness at the vulva, changing of the skin color, skin tone, skin texture, ulcerations, painful urination, painful defecation, or even the sexual activity becomes cumbersome because that area is inflamed, irritated. So that is the signs of the vulvar cancers. So these were the gynecological cancers. I have just given a brief about it. We can talk a lot about, but in concising it. Okay, so ovarian cancers would include the fallopian tubes as well. Uterine cancers, cervical cancers, vaginal cancers, and the vulval cancers. This consists of the gynecological cancer. The next which I want to discuss is the very common, like in the past 1 month, if I just have to name few people who had breast cancer, I have 3 people from my own relatives and my own families who have been diagnosed with breast cancer. So it's that quick. It's really that quick. Okay. It's a very common cancer which is being found, and 2 of them were after menopause, and 1 was in her early 40s when she got a diagnosis. Okay, so it's not so that the breast cancer would happen only after menopause or only after an age of 40 should you take care of your mammography and breast examination. It is very important that you should teach breast examination and perineal examination to every female you come across. And breast cancer is not limited only to females, even the male can suffer through it. Okay, so though the recurrency and the chances are less, but it's not negligent. Okay, so I would really like to emphasize a bit upon the breast cancers. So whether depending upon, again, they can be 2 types: the invasive breast cancers and the non-invasive breast cancers, meaning the one which are affecting the ducts, the milk ducts, the glandular tissues, and the other which are affecting the fibrous tissues. So depending upon that, they can be the invasive cancers and the non-invasive cancers. So stage 1 is the cancer in the breast, which is the tumor is less than 1 inch across. Tumor is less than 2 inch across, and it might have spread to the axillary lymph nodes. tumor is larger than 2, extensive, spread to the axillary and the nearby lymph nodes with dimpling and skin changes, and grade 4 is in widespread to the immediate regions of the breast, the lungs, as well as the vertebrae also in certain cases, right? So these are the breast cancers. If I have to give more brief about the breast cancers, being them common and a lot attached to the reproductive health as well as the pelvic floor issues. So breast cancer, as I said, can be diagnosed as 2 types, invasive and non-invasive. Further, depending upon their sensitivity towards the growth factors, they can be like hormone receptor positive, HER positive, or triple negative. So when we talk about the hormone receptor positive, means the breast cancer cells are receptive towards the presence of the estrogen progesterone hormones. So if they are receptive towards the estrogen hormones, like the higher the amount of estrogen in the body, the higher would be the growth of the breast cancer cells. So then they are known as the HRE, that is hormone receptive estrogen positive, or it can be hormone receptive progesterone positive, or it can be hormone receptive both, like estrogen progesterone both, or it can be in human HER, human epithelial growth receptor positive as well, or it can be triple negative, that there is no specific sensitivity towards the hormones or the HER genes, but still the cancerous cells are growing. Majority of the times those are the hormone receptive positive and estrogen dependent. So the females are given, like even after chemotherapy and radiotherapy or a surgical interventions, they are being given on long-term pills, estrogen intake inhibitory or estrogen receptor inhibitory pills are being given, in response to which the female might develop dryness of the vagina, she might develop recurrent vulvitis, recurrent vaginitis, and she can even develop weakness of pelvic floor as well as dyspareunia. Okay, so yes, definitely no matter what age breast cancer female you are coming across, it's important that you educate her about the involvement of the whole hormonal cycle and the pelvic floor as well. That will go for all the cases though, not just breast cancers. Yeah. So how can you diagnose, or what are the signs and symptoms? Lump in the breast, increasing the alteration of the size of the breast. Normally for every female, one breast would be heavier compared to other. No two breasts would be same, or even for the same female. Okay, but if the alteration, if the change of size is very significant, you're finding that there is some actual difference in your breast sizes or breast shapes, right? And if there is a discharge coming from the nipple, if the nipple is becoming sore, if it is becoming inwards, if the skin is becoming dry, it is like an orange appearance, like the like what we say, the pewdy orange appearance. That means scrambled, dried, orange peel-like appearance of the skin with the pain in the breast. So then those are the signs and symptoms of breast cancers. So how can we need to understand one thing, that we have to prevent, like prevention or early diagnosis is definitely better than regretting or repenting later. So how can we go for what self-examinations should we do, and should we teach our clients, our family members, relatives, friends, patients, everyone? So the first one is the breast examination, which it is not so that you should do it only after 40. Believe me, you should teach it to each and every female once you feel she is able to understand it. Okay, breast examination is really important to be done by every female. Typically, the pollution we are staying into, the stress we are living with, the rat race we are into, we need to make sure that things are not altering our physics, our body, right? So when we talk about the breast examination, I would really like to give you an idea on how shall you examine and what part should you examine. So I'm just explaining it to you. So first and the foremost, it is not so that you palpate superficially, okay, you are done. It's never like that. You have to actually go for a detailed examination of the breast tissue which is involved. Fine. The first and the foremost is uncover yourself and have a look into the mirror, that is there any change. See, the size would change for right and the left breast, but it should not be such of an alteration that, it is making a significant difference. Or till last month, the difference was just of some hardly noticeable, and now you can make sure that one is becoming more bulkier, it is becoming red, it is becoming inflamed. So if that is the case, that is the first alarm. Okay. But generally it will come late. Before that, there will be multiple changes which might already have occurred inside. So first is you look in the mirror and check it. Second is you can just keep your hand on one side and then you palpate throughout. So it's not so that superficially just the tissue, but actually deep and even the lymph node, the axillary lymph node. Many a times it might happen that you have nothing on this palpation, but you have a swelling in your axilla. And when you go for a diagnosis, it's actually late. So that can be in presentation. See, to have the common diseases in uncommon form is more common than to have the uncommon diseases in common form. Okay, so you should be mentally prepared for any of the presentations. So first is observation, then you palpate and check about your axilla. Third is you can just take your hand back and palpate the axilla throughout, and then you palpate the whole of your tissue, the whole breast tissue. So you can go in both the ways. You can go circular from out to in till the nipple and into out, and then anterior up to down and up to down. Make sure you do not have restrictive clothes. Otherwise, if there is any small nodule or node, it would right away be masked. Okay, so palpate throughout, in, out, out, in, up, down, down, up. So you can even make circular wedges and verticals. Okay, next is you lie down, come into supine line position and repeat the complete palpation again. Okay, and then is you just hold the nipple in between your hand and just press it and try to check whether there is any discharge. Okay, whether there is any nipple discharge or any pain, like when you are pressing the nipple, do you feel any pain, or whether there is any blood discharge or not. So that is the way you will be doing in breast examination. Fine. The next thing to understand, I will just play this slide. So if you want to, we'll just go through it. So with your arms relaxed to side, look for the changes in the shape and the color. If the nipple has charged colors, changed direction. Place your hand on your hip and press firmly. Bend forward, backward to look any changes if you have. Stand and with one hand behind your head, explore your entire breast, starting with the armpit and finishing with the nipple. With the tip of the finger together, feel your breast up and downwards, also in the round movement, starting from the outer part and pull inwards towards the nipple. Repeat the same in lying position and press your thumb and forefinger on the tissue around the nipple and look for any abnormal discharge or any abnormal secretion. So these are there are many times it can happen that on a female breast there will be multiple hair follicles. So you can even have folliculitis, so which might go unnoticed. So when you will press, some amount of pus discharge will come. So you need to understand whether this is a normal thing or an abnormal thing. But how will you understand? When you would be doing it regularly, only then you will be able to differentiate what is normal and what is abnormal. Fine. So it should be in detailed examination. It should not be just a superficial touch and you are done. Okay. And it is highly recommended that you do it religiously, at least once a month, to make sure that there are no any changes which are setting in and you realize it late. The second being the perineal examination. So you even teach the perineal examination to your friends, your families, your relatives, your mothers, your daughters, anyone you come across, any female should be able to know the perineal examination. So all you have to do is you have to observe the shape, the size, the symmetry, the structure, the color of the perineum every month. That is an external observation. Second would be an internal palpation, which we would be doing again. Okay, so this is just observing, just finding out like, is everything on the place, is everything normal or not. So that would be the perineal examination. The next thing to actually keep a note on is the vaginal discharge. See, your vaginal discharge would change throughout the month. It's never going to be the same. So it's gonna change throughout the month. Okay, when you are menstruating, you will have red colored discharge. Okay, you will have more of the red colored discharge. When you are into your fertile period, your discharge would change. It will become sticky. It will become more like egg white. It will be more mucoid because you are into your fertile window. You are ovulating, so definitely it will be there. And once you are on the day of your ovulation, and for a few days after ovulation, your discharge will be more it will be sticky, it will be still there, and then you might have dryness. So this discharge, every female will have her own pattern of discharge, her own smell of discharge, which will be musky. It will not be foul smelling. It will definitely be musky, but not a foul smelling. And for every female, the quantity, the quality, the smell, the type would change, but it should be the same every month. Okay, what you got in January should be there in the February, should be there, like it should be the same. If there is any alteration in the quantity of discharge, yeah, sometimes when you are stressed or when there is a lot of things going on, you might experience more discharge because of hormonal changes. But again, it will be just once a while. It would not be like continuously changing. So when if you find a yellow colored discharge, that shows a potential infection. If you find a thick white curdy discharge, that shows in yeast infection. Red discharge shows menstruation. Pinkish discharge and maybe a higher injury just in survival, vaginal laceration, inserting a tampon or something like that as well. Grayish discharge, bacterial vaginosis. Okay, if it is clear whitish fluid, then it is all normal. But if you are getting old brownish black discharge, that means it is an old bleeding which has happened and now it is coming out. So monitoring the vaginal discharge every month is important to make sure that your intimate health is well maintained. And this would be the first step to find out that whether there is any underlying pathology started or not. Okay. Now the most important question comes that why should we take care of the pelvic floor muscles for the patients who are undergoing chemotherapies or radiotherapies or maybe surgical resections. So whatever they are under influence of chemotherapy or radiotherapy, they are likely to develop weakness of pelvic floor muscles. They are likely to develop, if they have undergone radiotherapy, there are chances that, see, it's not so that the radiotherapy would kill only the cancerous cells. It will kill everything which is surrounding it. So the many females post radiotherapy will come with vaginal dryness. They might come with urinary incontinence. They might come with vaginal stenosis. They might come with fecal incontinence. They might come with sexual dysfunction. So all these things can present because of the a generalized effect of chemotherapy, generalized weakness, immunosuppression, and a localized effect of the radiotherapy or a surgical resection if done. Okay, surgical resection can be done in the case of any of the cancers if spread across. Okay, so that is the reason why we need to understand we need to palpate and assess the pelvic floor muscles. When we talk about the pelvic floor muscles, again giving you a superficial idea about what pelvic floor muscles are. So you can see the red colored structure here. Symphysis pubis, coccyx, ischial tuberosity right, ischial tuberosity left, and the red colored muscle which is covering here is the pelvic floor muscle. This is the superficial layer of pelvic floor, perineal body, superficial transverse perineal muscle, ischiocavernosus, bulbocavernosus, external anal sphincter, then the deep transverse perineal muscle, and then comes the internal pelvic floor muscle, the deepest layer of pelvic floor. So this being a female structure, you can see three openings: urethra, vagina, and rectum. And likewise, you have the pubococcygeus, iliococcygeus, and coccygeus. This one is obturator internus. And then you have the pubourethralis or pubovesicalis, pubovaginalis, and puborectalis. There are different school of thoughts when you talk about the pelvic floor muscles. Different people name them differently. This is the easiest way to remember, so I do this. You are free to follow whichever school of thought you want to. But these are the basic pelvic floor muscles when we are talking about. Just revising them once again for you. Superficially, we have 4. You can remember them as IBS-A, ischiocavernosus, bulbocavernosus, also known as bulbospongiosis by some. Superficial transverse perineal and external anal sphincter. So ischiocavernosus, bulbocavernosus, superficial transverse perineal, external anal sphincter, IBS-A. Okay. Then is the deep transverse perineal muscle, and inner one is the levator ani, the levator ani plate. So that is the pubococcygeus, iliococcygeus, and coccygeus. And the pubococcygeus have pubourethralis, pubovaginalis, and puborectalis. So these are the pelvic floor muscles, and these all can go into either tightness or weakness depending upon the involvement the patient is going through. So when we talk about the assessment, I'll just give you a brief about the assessment of pelvic floor muscles. So it will always start with the observation. So this is just a very interesting picture being reflected here. Hemivulvectomy, half of the vulva is being removed, and mastectomy on the left side. Think about the psychological impact the female would be facing after this. Today, when I'm looking into the mirror, I am aesthetically all good because I have both my breasts in situ. Tomorrow, there is no breast on one side or no breast on both the sides if it is bilateral. Okay, so it is a very big impact, a psychological impact to the female who is suffering through that, and even that can lead to sexual dysfunctions. As I said, it's not so that breast cancer would happen only after menopause. Young females can also have breast cancers, and those who are into their sexual life as well can face it, right? So it is very important to understand the psychological involvement as well in these cases. Next comes like in order to understand, find out the pelvic floor muscle behavior, we need to do few transvaginal examinations. So you can definitely teach transvaginal examination to your as I said, to your patients, to your mothers, to your relatives, your friends, anyone. That is to make sure that they are checking their pelvic floor muscle strength at least once a month. So not just to prevent from the cancers, but to prevent from any other pelvic floor dysfunctions like urine incontinence or dyspareunia, vaginismus, prolapse, hell lot of. Okay, so a simple test to be introduced here. We all are knowing about modified Oxford MMT, but the modified Oxford MMT has its own limitation, as we already know that it is not, with all the respect to the modified Oxford MMT and the way it was being introduced years back, where the hypertonous pelvic floor might not be in this picture, but the pelvic floor can go into either tightness or into weakness. So you need to assess the complete muscle, the muscle as a whole, whether can it relax when required and whether can it become tight. But the modified Oxford MMT do not measure the relaxation grade. Plus the grades are quite vague, fair, weak, moderate, which are really vague grades. So both these limitations are being overcome by Dr. Hed Desai sir, and when he introduced HEDS MMT, and it is a very proud moment for me to say that HEDS MMT is proudly introduced into the syllabus of Masters of Physiotherapy in Women's Health, and it is being practicing in 13 different countries now. And we have been publication on HEDS MMT as an outcome measure in ICS, International Continental Society, Melbourne, October 2021. So we did have a presentation there. So as well as in other national and international forums also, it has been presented as an outcome measure. It has a wonderful reliability and validity as well. So I would like to explain you HEDS MMT, and I would request all of you to make sure that you teach it to at least as many females as possible, so as to prevent them from any other pelvic floor dysfunctions as well. So the HEDS MMT can be done by your own self at least once a month. The grades are very simple, 0 being the baseline tone, that is the normal resting tone you all are here. So that is a baseline tone 0. -1 is inability to penetrate. Your muscles are so tight, they are so spasmodic that you cannot penetrate. Okay, that is inability to penetrate, -1. -2 is in symptomatic penetration. That symptom can be of pain, tightness, or discomfort. So if you are palpating your own self and if you find that you are unable to penetrate, that is -2, that is unable to penetrate, that is -1, that is inability to penetrate. If it is a symptomatic penetration, the penetration is very painful, very discomforting. So it is -2, symptomatic penetration. And -3 is an asymptomatic penetration, easy penetration or a complete relaxation. You are all relaxed. Now, once you're inside, you can ask the female to squeeze. And when she is squeezing, if you can feel mild pressure from either side, from any of the side, there is mild pressure, that is grade 1. If there is a circumferential grip, that is grade 2. And if there is a circumferential grip with upwards and inwards pull against resistance, that is a grade 3. So it is a very simple very simple test which can be done by all the females to find out and to prevent any upcoming pelvic floor dysfunctions. So it is grade 0 being the baseline tone, -1 being inability to penetrate, -2 being symptomatic penetration, -3 being asymptomatic penetration. 1 means mild contraction, 2 means grip with complete circumference, and 3 means in strong upwards and inwards pull against resistance. So Sir had developed the HMMT with the same vision that there shouldn't be any more silent suffering, and if we can give something as an tool to test your own self, it would be a really great blessings to prevent rather than to go for a curative measure. So with that vision, he introduced HMMT. So basically, if you want to have a healthy pelvic floor, your graph should be -3, that is completely relaxed, to +3, that is strongest contraction. Then there is a perfect scale as well. So perfect scale is Ben Laycock, and it has its limitation. Like in perfect scale, it is been based upon the performances upon modified Oxford, which itself is limited. And when we talk about the endurance, the perfect says that you have to measure the endurance where your MVC, that is maximum voluntary contraction, reduces by 50%. So pelvic floor muscles, maximum voluntary contraction 50%, that is a very subjective and very vague finding. What 50% for me? How can I define it? It is an objective thing. It's not 50% of 5 kg. It's like 50% of the strength. It's very objective. And due to these limitations, this was being introduced years back, in early 2004. That okay, if in nowadays, if we are ready to use the smartphones instead of small telephones, why should we use the same old method? We should definitely progress further and adopt new methods which can give a better idea of examination. So it is like head self-assessment, strength, endurance, repetition, and fast twitch. I'm not going in detail of this because I want to cover the oncovaginal rehab. So there is one simple rule of thumb that when we talk about the oncovaginal rehab, we need to understand that what is the diagnosis of the female. No matter she is coming with a gynecological cancer, a very important thing is only start the rehab after taking the approval of the treating gynecologist. Would like to, and treating oncosurgeon. Would like to repeat myself. Only take the patient after taking the consent from the patient, from the treating doctor, from the physician, from the oncologist, whoever involved. Okay, because what is more important? Life, right? You have to save the you should not do any thing which can directly hamper the improvement or which can directly interfere. You can give them an infection which is highly not needed that time. So make sure that whenever you are getting into the rehab, you have a proper consent from the patient and from the doctors, whoever are involved. Only after that you should go ahead. And then depending upon the symptom, with what symptom she is coming. Is she coming with incontinence? Is she coming with dyspareunia? Is she coming with fecal incontinence? She can be not a case of a gynecological cancer, but a colorectal cancer. Treated and now coming with a fecal incontinence. So even if she can be a patient for you, fine. So treatment, if she's coming with urinary incontinence, we can go for pelvic floor muscle strengthening exercises depending upon the strength of the pelvic floor muscles. We can even go for clockwise, ring clockwise strengthening using the PNF techniques, the irradiation techniques. The functional training can be done by using the vaginal weights and vaginal cones. And we should give them a proper home exercise plan and maintain a bowel and bladder diary. If it is a sexual dysfunction, then you can emphasize upon the orgasmic meditation. You can emphasize upon the importance of foreplay, different positionings, lubrication, pelvic floor relaxation techniques, scar tissue mobilization. You can teach them usage of the dilators and biofeedbacks and PF 360s and IFT and ultrasound can be done. Yeah. So with this, I would like to in this, why we do have a limitation of the time, so would like to end my speech here. And before I end, I would really like to give you an introduction of who we are, what Avao IPRI is. So we are under the legendary leadership of Dr. Heb Desai sir. I already have given you his introduction to all of you. And Avao IPRI has received certificate of recognition from Government of India with legitimate DIPP number exclusively for transvaginal transrectal pelvic floor rehabilitation. So we are the only government recognized institute with a DIPP number for exclusive transvaginal transrectal pelvic floor rehab. We are leading, we are training in almost 13 different countries. All these concepts and everything are being used in 13 different countries. Sir's book is Amazon's bestseller, which I already has introduced. These are his academic contributions. Sir's book has also been for endorsement from many national and international dignitaries like founder president of CEFOG, ex-president and vice president of FOXI, national president of Indian Medical Association, United Kingdom state consultant urologist, ex-president of Urological Society of India, and registered clinical exercise physiologist. These are the innovative properties of Heb Desai sir, and we have other brands as well. And yeah, so that was all from my side. Thank you very much for joining us on this occasion of World Physiotherapy Day. And I hope that this presentation, whatever we had for an hour, had given you an insight about, it's not that the pelvic floor does not exist in gynecological conditions. It do exist in gynecological conditions, and there is a wide scope. Depending upon the signs and the symptoms, you can definitely give them pelvic floor strengthening exercises or pelvic floor relaxation exercises, whatever are being required. So yeah, thank you very much for listening to me. And you can note down my number if you want to connect with me. It is 8000521503. I am available on WhatsApp on the same number, 8000521503. And my email address is cci.wowipri@gmail.com. Would like to repeat it again, cci.wowipri@gmail.com. Thank you very much. I would like to rest it here. So yeah, before I hand over, once again, I would like to thank IAP India Digital, IAPWC Utkal branch, and heartfelt thanks to Dr. Heb Desai sir for giving an opportunity and giving the dignity, the modesty, the limelight what pelvic floor and women's health were thriving for the years and opening a door of opportunities for all of us. Thank you very much, sir. Yeah. Over to you, Dr. Priyadarshini.
Yes, ma'am.
Yeah, I am done with my presentation. So I think if we have any questions, we can take them.
Okay, ma'am. If participants have any questions, they can please share them in the chat box, and ma'am will be answering all the questions. Anybody has any questions? Ma'am, I feel you have explained very nicely all details, so nobody has questions.
No problem.
But I can see raising of hand of 2 attendees. Okay, 3, okay. So you can put down your questions, or you can please type in the chat box what questions you have. Ma'am, chat box is disabled, it seems.
Okay, just a minute. I'll ask them to talk. I'll allow them to talk for a moment.
Yeah, sure, ma'am. As messages are coming, the chat box is disabled. So if you can see.
Yeah. Dr. Stiti, can you please unmute and ask your question?
Hello.
Yeah, please ask your question.
Yeah, it is a very pleasurable to see two terrific women on the same platform, Priyadarshini and Dhara. I'm extremely privileged to have both of you. You are, champion women, as I say. So my question was, you had mentioned about the vaccine, which the adolescent should be taken, should be given. So can you please repeat that? What kind of vaccination should the adolescent be given, or is it mandatory or it's optional?
So it is as such optional, but it is always good that it should be mandatory, because as I said that there are various brands which are coming with the bivalent and the quadrivalent HPV vaccines which are available. There are on the government websites also, as well as the city civic centers. Those are very easily available, the CHC centers. So Gardi is one, and but then they depending upon which one is available, it is highly recommended that after an age of 9 years, once the female is about to get into her puberty, it should be given to all the adolescent male as well as female, so as to prevent the spread. Why should it be given before in the adolescence? Is because they have yet not got into any sexual activity or any external exposure, so their body, the receptivity and the immunity, the immunity would be stronger. But if they already have started their sexual life, then in case if they have come across the virus, if there is any change of the virus, then the potency of the vaccine would decrease. And that is why it is recommended to be taken at an early age, like after the age of 9 years in the adolescent age group. You can select a bivalent or a quadrivalent, any of these vaccines. There are list of those. If you require, I can keep it on the WhatsApp group, so even others who have joined the WhatsApp group can get it. Dr. Siddhi, I hope you got the answer.
Yeah, I got my answer. Am I audible?
Yeah, you are audible.
Yes,
Yeah,
ma'am.
I got my answer. Thank you so much. The other one is about the abortion pills, which is there, that morning after pills. Does it affect, has it some effect on the cancer?
Yes.
Yeah.
It is being stated, like, see, earlier, nowadays, the OC pills which are coming, they are being given for multiple other diagnoses, not just for the oral contraceptive, but the uterine fibroids, uterine prolapse, endometriosis, dysfunctional uterine. There are multiple diagnoses for which they are being given. But an overdose of the OC pills, these are the ovarian exogenous hormones which we are taking. So anytime, whenever exogenous means produced outside the body, not produced by the body. So the females who are on a long-term OC pills do have an equal chance of, have an higher chance of getting any sort of gynecological cancers. So earlier the OC pills were coming like estrogen separately, progesterone separately, but nowadays it is being highly advised that it should be in the combination, and the drug therapy should not be exceeding more than 3 months at a time. You break it, then you do it. Again, there will be variations depending upon the severity of the condition, but a long-term OCP therapy it should not be given if there is an alternative, because that potentially increases the chances of the ovarian cancers and the uterine cancers especially.
Yeah. Thank you, ma'am. Thank you so much.
Thank you very much for asking the doubts. I hope you enjoyed the session.
Yeah, it is too less. I think we should be having you personally here in Odisha. You're
Sure.
planning that. Hopefully it finalizes.
Sure. Thank you very much for all that love and support.
Yeah.
Do we have any other questions?
Few other people raise their hand, so I would request them also to speak and ask your question, please.
There are no other people who have put up their hands right now. So if you have your questions, you can ask them, ma'am. Dr. Priyadarshini. There is no other hand which is raised.
Actually, ma'am, Dr. Anima also messaged that she wants to ask you
Doctor,
question.
what is her
Anima.
name?
Anima.
Okay, yes, just a moment. Yeah. Yeah, she can speak now. Dr. Anima, can you please ask your question?
Hello, ma'am. Am I audible?
Yes.
Okay. Thank you, ma'am, for the very nice informative session. I just want to ask, ma'am, what are the contraindications for the physiotherapist in case of
Contraindications, Dr. Anima, are you talking? Are you asking the contraindications for the pelvic floor rehab?
Yeah, for gynecological cancers. So, is there anything? I think for the
Ma'am, are you asking about that? What are the conditions where we shouldn't intervene?
Because I am unable to get the voice clearly. So if you can just.
Facts for physiotherapists means in which cases we should be very.
Ma'am, actually, maybe Dr. Anima wants to ask about the conditions where we shouldn't intervene. Like we should be very careful while intervening.
Okay.
As physios.
Yeah. So that's what I'm saying. Whenever it is in high grade oncological, gynecological cancer, high grade means a grade above than 2, 3, or which has almost metastatized. So in that case, because the patient will be on a long-term chemo and radiotherapy, so we should not go for any sort of invasive or non-invasive exercises till 6. If they have gone for any surgical intervention, then at least till the clearance from the treating oncologist, as I already mentioned, because many a times they go for radiotherapy implants as well. So in that case, giving a pelvic floor rehab can alter the output, or can increase. Like if you are using, suppose the patient is coming with incontinence and you are using IFT, what you are doing is you are increasing the blood flow to that area. You are increasing the chance of metastasis. So all the general contraindications which we follow for any metastasis, we would be definitely following in the cases of oncological cancers also, as well as pelvic floor rehab. If you like, when you are continuing the research, in case if you are getting approval from the oncologist to treat the case and the female is also ready, and while you are treating, if you come across any episode of bleeding or any episode of ulcer or any in increasing in the signs and symptoms, again you should right away discontinue your rehab and you should send the patient back, because the relapse can also be there. It is not so that once is gone. So there are certain cases, or if even after giving the consent before the treatment, if she is coming up with a relapse, again that is a no. So the baseline thing is you do not get into the field. And if you are specifically treating with vaginal stenosis cases, so those are the cases where the vaginal canal gets stenosed after the radiotherapies. So in these cases particularly, you have to be very precautious whenever you are asking them for dilator therapies, because the stenosed area can rupture and can bleed. Now that bleed might not be an actual cancerous bleed, that might be a bleed of the stenosed area, but again that should be very well communicated to the patient and the doctor and taken a permission and then gone for a vaginal dilator therapy, typically for the patients coming with dyspareunia or vaginismus after secondary vaginismus, secondary dyspareunia after the therapy sessions. I mean radiotherapy, chemotherapy, and other sessions. I hope I have addressed it correctly, Dr. Anima. Sorry, I am unable to hear you.
Hello, ma'am.
Your voice is very low.
Hello, ma'am. Does the radiotherapy really it causes weakness of pelvic floor muscle? Because most of the cases of the vaginal, there occurs stenosis, means there occurs tightness of the surrounding muscles. So, how does the pelvic floor weakness occur?
Dr. Anima, I'm really sorry, but I'm unable to. Dr. Priyadarshini, can
Ma'am,
you?
I would repeat the question, ma'am. She's saying that after radiotherapy, does pelvic floor muscle get weakened as there is vaginal fibrosis? So how does it is related? Am I correct, Dr. Anima?
Yes, ma'am. Yes,
Yeah.
ma'am. How does it
Yeah.
relate to
So
weakness?
I am not saying that it will always be weakened. There can be an incoordination. See, one thing which we need to understand is we should never judge when it comes to pelvic floor. It can be incoordinated. Incoordinated means the muscle have lost its property to contract completely and relax completely. So she might have vaginal stenosis is there. If I have to describe it with one of the case, 81-year-old case within a radiotherapy cycle, 2 years back came with a complaint of urinary incontinence. Now for her, the radiotherapy, whatever was given for her, the stenosis, the urethral adhesions happened in such a way that the strictures were so that they didn't allow the urethra to close and the pelvic floor to close and maintain the continence. So it led, but on the contrary, if there is a vaginal stenosis, as I said, that the fibrosis would lead to dyspareunia. This was a case of 81-year-old, so sexual activity was not on any of her priority list. So her major problem was incontinence. But again, depending, so every patient might have a different presentation. Every patient, no two patients with the same treatment will have a same presentation. So we should not conclude that they might go only for weakness. They might go for weakness, they might go for tightness, or so to find out what is the thing is the priority, the baseline thing is you do an examination for them and then decide what you want to give.
Okay, ma'am. Okay, ma'am. Thank you. Thank you.
Any more questions, ma'am?
Yes, ma'am. Yes,
I hope I
Okay.
answered your question, Dr. Anima.
yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you.
Anybody else has any other questions? No?
Dr. Priyadarshini,
Yes,
do
ma'am.
you have any more questions?
No, ma'am. I don't find anybody having questions. So shall we close the session, ma'am?
Yes, ma'am. You can continue with the vote of thanks if you want.
Okay.
Yes.
So we are going to close the session. Thank you, Dhara ma'am. It was really an enriching session. But as I would say, we need more of these sessions to enrich our knowledge and go towards this field of human health rehab education. And it's I don't have words, ma'am, to say. You described so beautifully about the anatomy and everything, the grades, Oxford grades, the modified Oxford grades. I was glued to the session. And thank you, ma'am, for giving your time and giving us so enriching webinar. I hope every one of our participants would have learned a lot and would look forward for your webinars. And as Siti ma'am already said, we look forward to have you in person for more of workshops, form of things. Thank you, ma'am. I would like to extend my special thanks to Dr. Siti Pragyan Dalavera, ma'am, our IAP Utkal branch president. Ma'am always motivates us, and ma'am will be always guiding us for everything. For everything, I mean everything. She'll be supporting in all the activities we do and this form of webinars. I would like to extend my thanks to Dr. Ruchi Vashni ma'am and Sanjeev Jha sir for their constant support in everything which we do. And as team member, I would like to thank IAP Utkal team and IAP Utkal WC team for their efforts, for their constant support in making this session a success. I would like to extend my thanks to the participants, those who gave their valuable time and attended our webinar. Now, last but not the least, I would like to thank Dr. Manisha ma'am, IAP Digital team, for making this webinar happen. Thank you, ma'am. Thank you to all the IAP team for the support. So herewith, I will close our session.
Thank you, Dr. Priyadarshini and Dr. Dhara Shah. On behalf of IIP, I would like to end this webinar now. Okay?
Yes, ma'am. Thank you.
Thank you so much.